Hi, this is Piyush Bhargava, and I have a few interesting cases to share with you. Our first case is a 85-year-old male with history of prostate cancer who presented with rising PSA. So the images on this slide are from a F18 flucyclovine PET-CT study, and we will start by looking at the rotating image. The rotating image shows physiologic distribution of the tracer and no evidence of metastatic disease. There is a focus in the pelvis, which is localized here in the right side of the prostate, with a suggestion of extension towards the rectum. And so, for local staging, this patient needs an MRI of the pelvis to further evaluate this focus. The interesting finding is seen right here in one of the vertebral bodies in the abdomen. We see two foci of increased uptake. These correspond to hyperdense vertebroplasty cement seen here on the fused axial PET-CT image. So is this finding real? Is there metastatic prostate cancer, or is this an artifact? So whenever we run into this situation, we evaluate the non-attenuation corrected images, and here we have the corresponding CT images in bone windows on the top and the non-attenuation corrected images at the bottom, showing no increased uptake and confirming that what we saw earlier was an attenuation correction artifact. Frequently, when there are hyperdense foci on the CT from vertebroplasty cement or prior internal fixation, sometimes even IV contrast or dental fillings, there can be attenuation correction artifacts showing up as FDG avid foci. So in those situations, we evaluate the non-attenuation corrected images to confirm that there is no abnormal FDG uptake in those regions. The characteristics of non-attenuation corrected images include skin activity, lung activity from scatter, underrepresentation of deeper structures, and these are useful to evaluate for artifacts. This is a good paper on the subject of attenuation correction, and from this paper there is a figure which I'm showing here comparing the coronal non-attenuation corrected image to the attenuation corrected image and then a corresponding CT. So skin activity, scattered activity in the lungs, and underrepresentation of the deeper structures are the characteristics of non-attenuation corrected images. Our second patient is a 59-year-old woman with uncontrolled hypertension and elevated catecholamines. And she first underwent a CT of the abdomen and pelvis with IV contrast looking for a adrenal pheochromocytoma. The adrenals were normal, but the CT scan shows this large enhancing mass arising from the right lateral wall of the urinary bladder and a focus of metastatic disease involving a right obturator lymph node. Here's the appearance of the mass on the coronal image. And so the concern now is that she probably has a urinary bladder paraganglioma, and a whole body staging was performed using gallium-68 dotatate PET-CT. Let's start by reviewing the whole body image. And so here we see physiologic distribution of tracer, gallium-68 dotatate, and we see multiple foci of increased uptake which involve the lungs, suggesting metastatic disease to the lungs, a focus in the midline, which was in the bones, and then a lot of activity in the bladder, which is in the primary that we saw earlier, as well as activity or radiopharmaceutical excreted from the kidneys into the urinary bladder. And so let's localize some of these findings on the PET-CT images. The first fused image shows the urinary bladder mass taking up the tracer. The second image shows the right obturator node taking up the tracer with focal intense uptake. And the third set of images shows a sclerotic bone metastasis, which shows intense uptake. So this patient has metastatic urinary bladder paraganglioma and was staged using a whole body gallium-68 dotatate PET-CT. Here is another great case report on this pathology using a PET MR in this patient. Our next patient is a 65-year-old male with prior biliary procedure who presented with skin oozing. And so we are looking at the same HIDA scan here using two different intensities. So let's first start by looking at the image on the left. So this cine image shows uptake in the liver. The hepatocellular function is compromised a little because we see cardiac blood pool activity persisting for a very long time. There is a contour deformity in the liver. This is from a hematoma that I will talk about later, and there is no evidence of bile leak. And so when we looked at the same set of images in a higher intensity, we start to find that there is a focus of uptake which appears right here. It's a linear focus. It extends from the liver to outside this patient's body through the abdominal wall. And so this is consistent with a subtle bile leak. So what's going on in this patient? Reviewing their prior imaging, we found two different studies. One of them is shown here on the left. This is a spot image from fluoroscopic image from a cholangiogram performed through a percutaneous biliary drain, and we can see here is the catheter coming down from outside the patient through the abdominal wall, the liver, the CBD into the duodenum, and the contrast has been injected. We see opacification of left-sided and the right-sided bile ducts, and part of the CBD with the contrast does not extend down into the duodenum, and so this external internal biliary drain is not working. And so this drain was removed, and this is a CT scan with a coronal image at the level of the drain, showing this hematoma that I talked to you earlier about, leading to the contour deformity on the HIDA scan. And then we see this tract of the prior catheter placement with granulation tissue, and this was the site of small volume of bile leak that we saw earlier on the HIDA scan. And this is a good review article on the subject of bile leaks. Thank you for watching.